Today's topic is atrial fibrillation. My heart is beating, if it's working, and I am fibrillating to deliver the speech because the speaker system is virtually dysfunctional, disorganized. So my topic is also dysfunctional and disorganized. What is atrial fibrillation? Atrial fibrillation is a very common cardiac arrhythmia characterized by seemingly rapid, disorganized, chaotic, irregular atrial electrical activation, resulting in loss of organized, coordinated atrial mechanical contraction. Such rapid and irregular atrial or electrical signals input into the AV node and junction, the functional status of which would determine the ventricular activation and the ventricular rate. That is usually irregular, often rapid, at a typical rate of 130 to 160 beats per minute, but may be excessively low in presence of AV nodal conduction disease or in a setting of high vagal tone. On the contrary, it may be very high, exceeding 200 beats per minute or even more in the presence of pre-excitation. So pre-excited AF should be suspected on a ventricular rate exceeding 200 or more precisely more than 250. Typical ventricular rate 110 to 160, কোনো টেক্সট বলা আছে 130 to 160, দুটো কথার মেনশন করার উদ্দেশ্য হচ্ছে কেউ হয়তো পয়েন্ট আউট করবে সেটা আপনি লিখেছেন 110 to 160 কিন্তু মুখে বলেছেন 130 to 160, both are correct. Now the epidemiologic point of view. The prevalence is about 0.4% of the population of India, 0.4% of the population of India, and 4% of the patients with structural heart disease, but unfortunately 40% of the patients with heart failure. The prevalence increases due to aging population and surprisingly improved treatment of the cardiac disorders because of certain drugs that improves the modern management of cardiac diseases may have pro-arrhythmic effect. So the prevalence is 0.4% of the general population, 4% of the patient with structural heart disease, and 40% of the patient with heart failure. Prevalence increasing with age as well as improved treatment for the cardiac conditions. Now, the etiopathogenesis and pathophysiologic basis. Atrial fibrillation is an arrhythmia that involves all the etiologic process of tachyarrhythmia such as abnormal automaticity, triggered activity, and re-entry circuits, especially micro re-entry circuits. Virtually, atrial fibrillation is a substrate-trigger interaction. It needs several prerequisites. প্রথমেই বলতে হবে যে প্যাথো অ্যানাটমিক সাবস্ট্রেট, দ্যাট মিনস অ্যানাটমিক atrial abnormality in the form of either fibrosis or presence of inflammation. Second, pathophysiologic influences in the form of autonomic remodeling, electroanatomic remodeling, electroionic remodeling, metabolic remodeling, তার সঙ্গে থাকছে আমাদের বেশ কিছু অক্সিডেটিভ স্ট্রেস and status of the or milieu of the pro-inflammatory state, that means the organokinase related influences. So in the presence of pathoanatomic substrate influenced by pathophysiologic basis, and arrhythmia is initiated by a rapidly firing focus, usually in the vicinity of the pulmonary veins or within the sleeves of the pulmonary veins, or maybe anywhere in the disorganized atrial tissues. The focus, most common site is pulmonary vein or sleeves of the musculature of pulmonary veins. Now, structural remodeling, that is changes in the atrium, either left atrium or right atrium. Changes means virtually remodeling is an adaptive response in response to some sorts of either pathologic or pathophysiologic insult, resulting in alteration, that is structural, cellular and molecular. So the structural remodeling, eক্ষেত্রে atrial abnormality in the form of atrial fibrosis. Second, the electrical remodeling, that may be of two types. আরো বলা ভালো এটা electroionic remodeling. That means the derangement of calcium regulation, that means calcium ion dysregulation, and second, ionic channel dysfunction. Both may lead to trigger activity, that is delayed after depolarization as well as early after depolarization. Then comes the hyperinflammatory milieu or environment, that is related to the release of cytokines and other inflammatory mediators. Then comes the metabolic stress in the form of meta-inflammation, then the oxidative stress producing reactive oxygen species. And lastly, the electroanatomic remodeling, that constitute a changes in the atrial tissues with the electrophysiological differences in the various parts of the atrium. This is the electroanatomic remodeling that may produce abnormal automaticity. So in a background of risk factors for genesis of atrial fibrillation, the anatomic substrate along with the pathophysiologic soil are triggering factor in the form of rapidly firing atrial focus may initiate a series or a multiple series of micro re-entry circuits resulting in chaotic atrial electrical activation, that is atrial fibrillation. Now in summary, structural remodeling, electric remodeling, that is the electroionic remodeling, ANS instability, that is autonomic dysregulation, milieu of hyperinflammation, oxidative stress and metabolic stress, electroanatomy And last but not the least, hemodynamic remodeling. Again, hemodynamic remodeling means changes in the blood flow, pressure, or volume, producing acute or chronic changes in the atrial wall tension that also contributes to the re-entry prone atrium or atrial substrate. So, in brief, an ectopic firing focus is responsible for genesis of atrial tachyarrhythmia in the form of atrial fibrillation. In a permissible remodeled atrium, permissible remodeled atrium. That means various sorts of remodeling I have already discussed. This is the abbreviated form. The calcium dysregulation, this is the background. That means the modifiable and non-modifiable risk factors for the genesis of atrial fibrillation. On this background, electrical remodeling, calcium dysregulation, ionic channel dysfunction, structural remodeling, atrial fibrosis, and autonomic remodeling, that is dysregulation of the cardiac autonomic nervous system, producing two things: ectopic firing focus and the permissible remodeled substrate, that is the anatomic substrate. Abnormal atrium produces re-entry phenomenon. Main mechanism is a series of or a collection of multiple micro re-entry circuits coupled with triggered automaticity as well as abnormal or enhanced automaticity. Now, classification of AF. Traditional classification is first diagnosed atrial fibrillation, অর্থাৎ detection of atrial fibrillation irrespective of duration or severity of symptoms or of temporal pattern. First diagnosed AF, that means detection of AF irrespective of temporal pattern, severity, or duration. Then the paroxysmal AF, that means spontaneous onset but spontaneous or induced termination within a period less than 7 days. Then the persistent, that means sustained for more than 7 days but certainly less than 12 months or 1 year. Long-standing persistent, that means more than 12 months, and permanent, no cure is available, therapy is not indicated, and the patient should be managed on the basis of SDM, shared decision-making process. That is a logical discussion between the physician and the patient to share a management strategy in the light of evidence-based knowledge as well as patient's desire, goals, and values as well as preferences. Now, this is the stage of evolution of atrial fibrillation. First, যেটা অলরেডি বলার চেষ্টা করলাম সেটা হচ্ছে যে ট্র্যাডিশনাল ক্লাসিফিকেশন, ফার্স্ট ডিটেক্টেড AF or first diagnosed AF, paroxysmal AF, persistent AF, long-standing persistent AF, and permanent. Now, stage and temporal evolution of atrial fibrillation. At risk for atrial fibrillation, no evidence of atrial fibrillation, but the associated risk factors are responsible or present. It is at risk for atrial fibrillation, stage 1. Stage 2, pre-AF, that means pre-atrial fibrillation. Presence of structural and or functional or electrophysiological abnormality without documentation of AF, that is the pre-AF, that is pre-atrial fibrillation stage 2. That means atrial enlargement or presence of the frequent atrial activity, short burst of atrial tachycardia or atrial flutter. Then comes stage 3, that is the paroxysmal AF, 3A, second 3B, that is the persistent AF, 3C, that is the long-standing, persistent, and 3D, post-ablation AF, that is 3T, and stage 4, this is the permanent atrial fibrillation. তাহলে এখানে একটা বেসিক প্রশ্ন আসছে, হঠাৎ পোস্ট অ্যাবলেশন সাকসেসফুল এফ এটাকে কেন রাখা হয়েছে টেম্পোরাল প্যাটার্ন অ্যান্ড স্টেজেস অফ অ্যাট্রিয়াল ফিব্রিলেশন এভলিউশনের ক্ষেত্রে? এটা কি কোনো যুক্তি আছে? সাকসেসফুল অ্যাবলেশনের পরেও কিন্তু এএফকে ক্লাসিফিকেশনে রাখা হয়েছে। Stage 1 at risk for atrial fibrillation, stage 2 pre-atrial fibrillation, stage 3 A paroxysmal, B persistent, C long-standing persistent, and D AF following post-ablation, or more precisely successful post-ablation. Because after ablation therapy there is a blanking period in which transient tachyarrhythmia may occur due to inflammation produced by the procedures. That is transient and is not classically pathological, but monitoring and reassessment or re-evaluation should be focused on that. That's why successful ablationের পরের এফটাকেও কিন্তু atrial fibrillation classification রাখা হয়েছে, and stage 4 means permanent atrial fibrillation. Again, on the basis of clinical concept, atrial fibrillation can be divided into two: clinical atrial fibrillation and device directed or subclinical atrial fibrillation. Now, what is clinical atrial fibrillation? Symptomatic or asymptomatic atrial fibrillation with documentation of atrial fibrillation in ECG, either standard 12-lead ECG or other ECG devices. Device detected atrial fibrillation, that means asymptomatic or subclinical atrial fibrillation on the surface ECG and is detected by the device, that means intracardiac implanted electronic devices. This is also known as device detected atrial fibrillation. Now, clinical manifestations of atrial fibrillation. Clinical manifestations. অন্যভাবে বলা হলো evaluation that depends on symptoms, signs and investigations including the imaging. What are the symptoms of atrial fibrillation? Symptoms related to the rapid irregular ventricular rate. Second, the hemodynamic consequences of the atrial fibrillation. Third, complications resulting from thromboembolic phenomenon. And fourth, the overall impact of atrial fibrillation to cardiovascular function with passage of time. Symptoms usually categorized as symptoms of tachyarrhythmia, like palpitation, chest discomfort or chest pain, dyspnea, exercise intolerance, or signs of complications in the form of features of stroke, as well as in long-standing cases, multi-infarct dementia and impairment of the cognitive function. তাছাড়াও ক্লাসিক্যাল বা ট্র্যাডিশনাল সিমটমসের মধ্যে প্রিসিনকোপ বা সিনকোপাল অ্যাটাক symptomatology and the signs: rapid irregular ventricular response or rapid irregular heart rate or pulse rate, presence of hypotension, loss of airwave in the jugular venous pulsation, impact of cardiac sinus masses. It does not terminate the atrial fibrillation, but it may reduce the rate of ventricular response by increasing the or blockage or concealed blockage at the AV junction. Then the intensity of phase 1, that is variable in intensity. These are the clinical findings. So findings due to atrial fibrillation or signs due to atrial fibrillation. Then signs due to the cardiovascular disease responsible for atrial fibrillation. Then signs due to complications by atrial fibrillation, and lastly stigma of cerebrovascular disease or signs due to thromboembolic complications. So symptoms and signs কে আমরা এইভাবে ক্যাটেগরাইজ করতে পারি। Then comes the investigations. First of all, a comprehensive metabolic panel like liver function test, renal function test, blood biochemistry including the electrolytes. এগুলো কেন বলছি পরে ব্যাখ্যা করা যাবে। Screening for diabetes mellitus, hypothyroidism or hyperthyroidism, that means thyroid disorders, and clinic for chronic kidney disease. Then comes the standard 12-lead ECG and on occasion 24 hours Holter monitoring, followed by imaging in the form of classical echocardiography, that is the transthoracic echocardiography, or if necessary, transesophageal echocardiography. Now, AF burden and impact and outcomes. Symptoms already described. Then comes the adverse outcome that include recurrent hospitalization, heart failure, ischemic stroke, thromboembolism, impairment of cognition and vascular dementia, depression, impaired quality of life. Then comes impact on the society, such as healthcare and society. তার মধ্যে পড়ছে increasing prevalence, high cost of therapy, impact on individuals, family and the community. The outcome or impact on the society should also be considered in the management strategy of atrial fibrillation. Electrocardiographic diagnosis, POF. Usually no discrete POF is available, or in case of coarse atrial fibrillation, POF is present with a rate of 350 to 600 beats per minute. Usually there is no discrete POFs. In place of that, there is undulating or oscillating baseline. The ventricular rate is irregular with narrow complex QRS morphology, except with certain situation like situation of pre-excitation. This is the undulating baseline, and this is the P, and this is the second P, the duration, the rate is about 300 to 600, এখানে যেটা দেখা যাচ্ছে সেটা about 400. The ventricular rate is 110 to 160 and is usually irregular. The QRS morphology is normal, that is the narrow complex tachycardia, except the situation of pre-excitation. Now, pillars of management of atrial fibrillation. That means access to all aspects of care to all on the basis of SOS. That means stroke risk assessment, optimization of the modifiable risk factors, and symptom management. Then comes the shared decision-making process, like in case of permanent atrial fibrillation, or management strategy according to patient's preferences. Then comes the risk factors and enact behavioral changes. রিস্ক ফ্যাক্টর মনে রাখার সুবিধার জন্য একটা নিমোনিক ইউজ করা হয় ফ্রম হেড টু টোজ। হেডের এইচ মিনস ফর heart failure, E, excessive exercise. Excessive endurance exercise may precipitate or produce atrial fibrillation. A means for arterial hypertension and D means for diabetes mellitus. The head to toes, T for tobacco use, that is smoking, O for obesity, E for ethanol or alcohol intake, and lastly S for sleep apnea. These are the comorbidities and risk factors associated with atrial fibrillation. So basic management strategy is access to all aspects of care and goals to all patients. On SOS basis, stroke risk assessment, optimization of the modifiable risk factors, and lastly symptom management. Again, it can be elaborated into more is stroke risk, then symptom severity. Symptom severity के আমরা চারটে ক্যাটাগরিতে ভাগ করি, 1, 2A, 2B, 3 and C. Then severity of the AF burden with temporal pattern, like first diagnosed AF, paroxysmal, persistent, long-standing, persistent or permanent. Then the comorbidities, that is the head to foot. So the subcomponent are stroke risk, symptom severity, symptom of AF burden, and lastly the substrate severity along with the comorbid conditions. Now the symptom severity. Stage 1 symptom or score 1. No symptoms, no limitation of physical activity. 2A, mild symptoms, no limitation of physical activity. 2B, moderate symptoms, normal activity is not affected by symptoms related to AF, but patient is troubled by symptoms. Stage 3, severe, normal activity is affected by symptoms related to AF, and lastly disabling, it is the stage 4 symptoms, normal activity discontinued. So in summary, the basic management pattern is control of patient symptoms through a strategy of rate control and rhythm control. Second, mitigation the thromboembolic risk And third, addressing the modifiable risk factors for progression of the disease process, that means the process of atrial fibrillation. Now, institution of therapy or mitigation or avoidance of the complications of thromboembolic manifestations. We have to balance between two sets of parameters. One, for chances of thromboembolic risk. On the other hand, chances of bleeding by the antithrombotic therapy. The chances of thromboembolic risk is assessed by CHA2DS2BASC. C, that means congestive heart failure, scoring 1. Age, hypertension, scored 1. A2 means age more than or equal to 75, that is 1. D, diabetes mellitus, 1. History of stroke, TIA or previous thromboembolic complications, that is 2. Vascular disease like aorta, peripheral arterial disease or coronary vascular disease. Point 1. Age in the range of 65 to 74, that is 1. And SC, sex category, that is female, 1. Annual risk score 0 point, that means 0 risk of bleeding, no anticoagulation is recommended. Second, 1 point means 1.3% risk of thromboembolic complications. Antibiotics should be considered, especially in case of male subject. And score 2 or more, 2.2% risk for thromboembolic complications, anticoagulation is mandatory. Again, CHA2DS2BASC. C, congestive heart failure. Age, hypertension. A2, age more than or equal to 75. D, diabetes mellitus. S2, stroke, tear or thromboembolism. V, vascular disease. A, age in the range of more than 65 but less than 74. On sex category, there is the female, 1. Now, on the other hand, this is the hash blade scoring system for chances of bleeding by instituted anticoagulation therapy. Hash, age for hypertension with a systolic BP more than or equal to 160 millimeter of mercury. Then abnormal renal function, 1. Abnormal liver function, 1. Stroke in the past, 1. Bleeding diastasis, 1. Labile INR, also 1. And elderly subject, ekatre age more than or equal to 65 years, scoring 1. And drugs as well as alcohol intake. Illicit drugs, 1. Alcohol consumption, 1. Has blade scoring. So a balance between the has blade scoring system and the previous scoring system is responsible for consideration of the anti-thrombotic or antiplatelet therapy. A3, a score of 0 means 1% risk of bleeding. Score of 3 or more means more than 5% risk of bleeding. Now the oral anticoagulation, classical or practical implementation. Atrial fibrillation. Atrial fibrillation assessment of risk factor CHA2D S2 VASSC score 0. No antithrombotic therapy 1. In case of female, no antithrombotic therapy. In case of male, antithrombotic therapy may be considered. Or score 1 or 2 or more antithrombotic therapy, and that is balanced judged by the Hasbett scoring system, and the score leads to institution of direct oral anticoagulation therapy. অ্যান্টিকোয়াগুলেশন থেরাপিকে এএফ সেটিং আমরা তিনটা ভাগে ভাগ করতে পারি। একটা হচ্ছে ইনহিবিটর অফ অ্যাক্টিভেটেড ফ্যাক্টর 10, অ্যান্টিথ্রম্বিন ইনহিবিটর অ্যান্ড ভিটামিন কে অ্যান্টাগনিস্ট। তার মধ্যে থাকছে ড্যাবিগার্টন, তারপর অ্যাপিক্সাবেন, রিভারক্সাবেন আর ভিটামিন কে অ্যান্টাগনিস্ট, ওয়ারফেরিন সোডিয়াম। Management strategy again, rate or rhythm control strategy, then catheter ablation, then other methods like surgical therapy. মাঝখানে থাকছে ablate and base, and it also depends on newly diagnosed AF, paroxysmal AF, persistent AF, permanent AF, and the drug refractory AF. Now, most important is newly diagnosed or first detected atrial fibrillation. The new onset atrial fibrillation, hemodynamic instability, direct cardioversion, hemodynamic stability, then go for reduction in the rate by means of IV beta blocker or calcium channel antagonist or decoction or a combination thereof. Then go for two options, either spontaneous conversion and maintenance in sinus rhythm follow-up. No conversion or recurrence, then go for anticoagulation therapy that should be initiated 3 weeks prior to the anti-arrhythmic therapy or rhythm control strategy and should be continued for at least 4 weeks thereafter or even more. And এক্ষেত্রে দুটো অ্যাপ্রোচের কথা বলা হয়, একটা সরাসরি ট্রান্স ইসোফেজিয়াল ইকোকার্ডিওগ্রাফি করা উচিত to detect the presence of thrombus in the left atrial appendage. In that particular setting, you should go for anticoagulation and wait, and then go for antiarrhythmic therapy. In absence of the detected thrombus on transesophageal echocardiography, you should go for anticoagulation as well as antiarrhythmic therapy. Then again, recurrence or symptoms produce or symptom related arrhythmia, then repeat the DC cardioversion with another antiarrhythmic agents. Again recurrence or sustained, then go for ablation therapy. Again, if symptoms arise from symptomatic bradycardia or chronotropic incompetence as a result of catheter ablation, go for surgical therapy like maze operation, isolation of the pulmonary veins, or এটা আগেই বলা দরকার ছিল ablate and pace. That means symptomatic bradycardia or chronotropic incompetence. First option, ablate and pace, that means implantation of a permanent pacemaker. যদি কাজ না করে, go for surgical intervention in the form of isolation of the pulmonary veins or maze procedures or external beam radiation or field electroporation. এই এতগুলো জানার দরকার নেই। এটা অলরেডি বলা হয়ে গেছে। Drug resistant or drug refractory atrial fibrillation. Again, AV nodal ablation, AV nodal modulation, then focal ablation, ablation and pace, that is the pacemaker therapy, implantable atrial defibrillator, and lastly surgery, maze, pulmonary vein operations. রিদম কন্ট্রোল স্ট্র্যাটেজি, সাধারণত আমরা ইউজ করতে পারি ক্লাস 1 অ্যান্টিরিদমিক ড্রাগস, প্রোপাফেনন, ফ্লেকিনাইট, ডাইসোপাইরামাইড। কিন্তু নেগেটিভ আইনোট্রপিক এফেক্ট এবং প্রো এরিথমিক এফেক্টের জন্য স্ট্রাকচারাল হার্ট ডিজিজ বা হার্ট ফেলিওর থাকলে এগুলো ব্যবহার করা যাবে না। The first line therapy, class 1 antiarrhythmic drugs like propafenone, procainamide, and disopyramide, but definitely in absence of structural heart disease or heart failure. Then we should go for the class 3 antiarrhythmic drugs like sotalol and dofetilide, but the main side effect of dofetilide is QT prolongation, or in the presence of previous QT prolongation, induction of the ventricular tachyarrhythmia. Then we should consider the amiodarone, relatively safe. It reduces the rhythm or conversion the rhythm in about 2/3 of cases. কোনো কোনো বইতে বলা আছে 50% of cases, but the long-term side effect is thyroid dysfunction, pulmonary fibrosis, and liver dysfunction. So, long-term complications of the antiarrhythmic therapy should invite us to sit for the SDM as the shared decision-making process. Now, all of the care, that is C, comorbidity, hypertension, heart failure, overweight, obstructive sleep apnea, alcohol. A, that is the acute stroke and thromboembolism. Then the reduction of the symptoms by rate or rhythm control strategy, and then E, evaluation and dynamic assessment. That's all care regarding the atrial fibrillation. Now, atrial flutter. Atrial flutter is again a macro reentrant tachyarrhythmia arising from a larger area of atrial tissues, usually associated with the scar or fibrosis in the atria. The most common site of origin is the cavo-tricuspid isthmus, that means orifice of the inferior vena cava and tricuspid valve annulus. The origin is cavo-tricuspid isthmus. That's why common atrial flutter is known as cavo-tricuspid isthmus dependent atrial flutter. That means the rate is usually regular, typically at a rate of 240 to 300 beats per minute. The ventricular rate is regular at a rate of 130 to 150 beats per minute. Atrial flutter is associated with heart disease, pulmonary disease, post-cardiac surgery, or atrial fibrillation, as well as after treatment of atrial fibrillation or as a complication of the antiarrhythmic drugs. Management profile is more or less same like that of atrial fibrillation. Types of atrial flutter. The common atrial flutter, this is the retrograde or anti-clockwise fashion. Re-entry in the anti-clockwise fashion is the common atrial flutter, producing negative flutter waves or negative A waves or negative sawtooth pattern appearance. This is the typical or common atrial flutter. Origin is the right atrium, especially in the zone of the cavo-tricuspid isthmus. This is the anti-clockwise re-entry circuit. Is the most common. And atrial flutter, this is classical clockwise pattern of re-entry, sawtooth appearance in the atrial fibrillation. So types ki typical atrial flutter, আগেরটা ভুল বলেছি ওটা atrial flutter হবে. Types of atrial flutter, typical atrial flutter, that is anti-clockwise fashion. Reverse typical atrial flutter, that is clockwise fashion. And atypical atrial flutter, that means origin of the atrial flutter other than the cavo-tricuspid isthmus, that is anywhere in the atrial tissues with scar or substrate for genesis of macro re-entry phenomenon. Counterclockwise typical atrial fibrillation. This is a negative P. Sawtooth appearance, this is the counterclockwise or classical or typical. These are clockwise, the P wave is positive, sawtooth pattern. This is the atypical, that may be positive or negative, that may or may not follow the 2:1 AV conduction. The atypical atrial flutter may be confused with focal atrial tachycardia. দুটো দেখতে more or less একই রকম. Now last of today's discussion, multifocal atrial tachycardia. পরিষ্কার করে বলেই দিচ্ছে মাল্টিফোকাল অর্থাৎ একাধিক জায়গা থেকে. Atrial, that means within the atrium, either right or left, and definitely tachyarrhythmia. A rhythm with at least 3 distinct P waves. কেন multifocal? At least 3 distinct P wave morphology. Usually at a rate of 100 to 150 beats per minute. First point, distinct 3 P wave morphology. কারণ মাল্টিপল সাইট অফ অরিজিন বোঝানোর জন্য আমার ডিফারেন্টলি 3টে ডিস্টিংক্ট ওয়েভ মরফোলজি দরকার. Rate usually in the range of 100 to 150 beats per minute. Mechanism is by triggered automaticity or triggered activity in a setting of chronic hypoxemia, especially in a setting of chronic obstructive pulmonary disease, or chronic lung disease with respiratory insufficiency. These PF morphology, these PF morphology, these PF morphology ভালো করে লক্ষ্য করে দেখো এই তিনটে ডিস্টিংক্ট PF morphology কোনো সিমিলারিটি নেই. So presence of three or more distinct PF morphology with a ventricular rate of about 100 to 150 beats per minute in a setting of chronic lung disease with or without respiratory insufficiency constitute the diagnosis of multifocal atrial tachycardia. Management, usually drug therapy is ineffective. On occasion, troubles or disabling symptoms may be alleviated by calcium channel blocker, and beta blockers should be avoided due to the presence of the chronic lung disease. But drug therapy majority ক্ষেত্রে unsuccessful. সেক্ষেত্রে basic correction of the background pathology with supplementation of the oxygen with or without ventilation, either mechanical or non-invasive, will ameliorate the tachycardia. That's all.